Welcome, everyone, and thank you for joining us for today's seminar, Novel Application of Molecular Diagnostics in Infectious Diseases, presented by Dr. Esther Babady. She is the Director of Clinical Operations for Microbiology Services, Associate Attending Microbiologist for the Departments of Medicine and Laboratory Medicine, and the Director of Clinical Microbiology Fellowship at Memorial Sloan-Kettering Cancer Center. My name is Susie Valdez, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is a leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I want to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want during the presentation. Simply click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box. Our speaker will respond to your questions via email following the presentation. If you have any trouble seeing or hearing this presentation, simply click on the Ask a Question box and let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right corner of your presentation window and follow the process to obtain those credits. Without further ado, please join me in welcoming our presenter, Dr. Esther Babady. Welcome, Dr. Babady. You may begin.
Thank you very much for the introduction, and thank you for the invitation to present today. As mentioned, the topic of my presentation will be on novel applications of molecular diagnostics in infectious disease. So just to get us started, I want to just start by pointing out some of the things we all are aware of. Molecular tests have revolutionized the diagnosis of infectious disease. And here I'm showing you some of the ways this has happened. From the very slow viral culture that took many weeks for the laboratory to obtain a result, molecular diagnosis have been able to make this process quite fast by having testing that is done really rapidly, to the point that these days 20 minutes at most for many of the tests that we use is the time frame in which we get our result. In addition to the rapidity with which we are able to obtain tests using molecular diagnostic, we also have an increase in the accuracy from going to a test like a DFA, for example, where there is some subjectivity in interpretation of the result. With a molecular diagnostic, the objectivity and allows for a more accurate interpretation. Furthermore, we have seen a significant increase in the sensitivity of the assays. So again, showing a smear where, depending on the abundance of the pathogen on the side, you may or may not get a result, but with a molecular test, the sensitivity increases in such a way that we are able to diagnose most infections if a pathogen is present. In addition to sensitivity, the specificity of the diagnosis has also been significantly improved with molecular diagnostic, so much so that unlike, for example, CPE as shown on this image, where a technologist had to look and decide what the CPE looked like to make a diagnosis of a viral infection, with a molecular diagnostic, the specificity of the assay in terms of how it's designed allows, again, for a accurate, sensitive, rapid, and specific result to be obtained for our patient, right? So we noticed that the molecular tests have really changed the way we've done diagnostic. And this started about almost 30 years ago at this point. And these assays continue to improve in terms of their turnaround time, but also in terms of sensitivity and specificity. As mentioned a little bit earlier, these also have been simplified, right? So the original molecular tests tend to be very cumbersome and only available in big reference labs. The current assays span the range of simplicity from the really, really simple to the really cumbersome still. However, The availability of tests, as shown on these slides, has really allowed for molecular diagnostic to be implemented in a variety of settings. So these days, we are able to talk about sample-to-result platform, CLIA-waived, and point of care, something that is really, really exciting and shows how much improvement and how much development there's been in this field, to the point that now even in emergency room can do a molecular test, for example, for influenza. So these molecular tests have really improved and have simplified many of the current workflow that we are aware of. In addition to this really simple sample-to-result, CLIA-waived, and point-of-care testing, there is also been a push by many manufacturers to help the laboratory consolidate a lot of the testing that we currently do on a variety of platforms, to be able to consolidate them on one platform that is able to run both laboratory developed tests, but also the commercially available IVD clear assay. So this has been a second improvement, or one of multiple improvements, I should say, in molecular diagnostic, allowing for automation and consolidation from the original very manual, very cumbersome test to what we are experiencing now in the ability to add a sample to a platform with minimal user input and get a result interface into the clinical information system. So from the original tests that were developed almost 30 years ago to where the field is right now, it has been a significant improvement. However, gap still remains and several unmet needs still exist. And because I'm from New York City, when I think about a gap, I'm obviously thinking about gap between the subway platform and the train. And so this is going to be the icon that I'm using throughout the talk to show some of the gaps that still exist in this field that already has done so much, and some of the emerging testing that is coming to try to fill this gap. So for today's, our learning objective will be that after this presentation, the learner should be able to, one, describe existing gap in the rapid diagnosis of infectious disease, be able to discuss the advantages and limitations of some of our current tests for the diagnosis of infectious disease, and finally be able to list some of the emerging molecular methods and the potential impact on the rapid diagnosis of infectious disease. And there's quite a few emerging diagnostic tools coming up in the field. However, in this particular presentation, I'll only cover a few of them, right? So in order to frame this discussion, I'm going to use a couple of cases to highlight some of these gaps and how some of these new methods can hopefully fill some of these unmet needs. So starting with our first case. So case one is that of a 1-year-old patient with who's suffering from hemophagocytic lymphohistiocytosis. So it's a very mouthful, and from now on we call it HLH, right? So this is an immune disorder, and in order to treat this patient, she needed to have a bone marrow transplant. So the patient received an allo hematopoietic stem transplant, and the mother was the donor. As part of the course, she ended up having chronic gut versus host disease, or GVHD, and she also suffered from a persistent human herpes virus 6 viremia. So in this graph, I'm just showing you some of her viral load over the course of a few months. And so patient started with very low level, a bit lower than 10,000. And then a few months after her HSD treatment, she ended up having a spike in her viral load that went from about 10,000 to 60,000. So the question that the clinician was asking in this particular case, and just to, before we moved on, but when you look at the result of the patient in a logarithmic scale, although the raw number showed a big spike, the spike by on a logarithmic scale was a little bit less pronounced, but yet still an increase. So the clinician then was questioning the result and asking, is this really HSV6 infection? Is the patient viremia really a reflection of a disease, a change in the state of her infection? And if so, is this something that will require the patient to undergo treatment for this particular viral infection? So just so we are all on the same page, let's just review for a second what the concern is really here. So HSV6, or human herpes virus 6, is a little bit unique among the herpes virus in that it can become chromosomally integrated. So what is chromosomally integrated human herpes virus? So this is a condition in which the complete genome of the virus is integrated into the host germline, and this is then vertically transmitted in a Mendelian manner. And so essentially, although this is a viral infection, the integration of the virus into the genome and to the X chromosome in particular allows it to then get transmitted like you would any other just mutation or genetic disease, right? So the X chromosome would be given to one of the kids, a potential between the parents. And so that transmission would not necessarily be a reflection of a viral disease, but rather more of a genetic infection or a genetic disease in this particular case. This is a little bit more highlighted on this figure that basically show a karyosome where chromosome, you look at the telomere of this chromosome and you can see the presence of the HSV6 virus, and in this particular case is HSV6B, one of the two genotypes of this virus. So a patient being positive for HSV6 may be just a result of an infection that's being reactivated as would any herpes virus, or could be a reflection of the chromosomal integration into the host genome. So how do we diagnose HSV6 disease? Well, as we mentioned, some of the earlier improvement in molecular diagnosis meant that we were able to diagnose patients using real-time PCR. So for HSV6, one of the tests that we currently use are quantitative PCR on a plasma sample. So there is a lot of advantage to this method, but it's also very sensitive to some of the pre-analytical issues that are related to maybe the processing, the storage, the handling of the specimen, which can yield false negative or false positive results, or even some inaccurate quantitation. Furthermore, depending on the methodology that is used, a result of a quantitative test obtained, let's say, at Memorial Sloan-Kettering, is very unique to that particular assay, the particular assay in use at that facility, and doesn't necessarily translate well in terms of being comparable to results obtained at a different location. So in any case, quantitative plasma PCR, this is just showing again a graph of a real-time assay. We have a standard curve, and then we get a number, right? So this quantitation tend to be expressed in the copy per mils, as shown in the, some of the slides a little bit earlier, or you can convert that to log per copies per mil. But again, very specific to the laboratory in which the assay is being performed. To diagnose chromosomally integrated HSV6, however, you have to go beyond just the quantitative PCR. Some of the options that are out there that are available look at the hair follicle or the fingernail clipping, again, looking at the presence of this virus in the host genome. Another way would be to look and compare the quantitative result from a whole blood sample from a parent to a child. And if there is a certain difference in the viral load between those that are at least greater than 5 logs, that would be suggestive of maybe a viral infection versus chromosomally integrated HSV6. Another option will be then to look at HSV6 mRNA testing as more of a reflection of a replicating virus and active infection. Again, primarily focus on real-time PCR or quantitative PCR or qualitative PCR the way we have it now. So just to summarize a little bit of what we currently do, we have a lot of advantage with real-time PCR for quantitative PCR for virus, right? So this has allowed us to replace some of the cumbersome and sensitive viral culture methods. Remember from the earlier slide, when you look at CPE, imagine having to do that for monitoring of an infection, especially quantitative monitoring of viral load, that was not a very practical approach. And so real-time PCR has allowed us to move away from this. It allows the measurement of the viral load not just in plasma or whole blood, but in any other specimen type. And depending on the assay, the turnaround time can be a few hours as opposed to several weeks, if we think about how viral culture works. In particular, for chromosomally integrated HSV6, we are looking at different methodology to be able to distinguish between an acute HSV6 infection and a chromosomally integrated one that is not in need of treatment. And just to summarize, qPCR and mRNA are some of the targets that we look at to make that diagnosis. One of the gaps then that this particular case highlights is the fact that it's quite challenging, especially for virus, to be able to distinguish between an integrated virus and an active infection. Furthermore, for many of the other herpes virus, being able to distinguish between active and latent infection with the current molecular tests we have is not always as practical. And this also applies to other infection, bacterial or fungal infection, when the target is DNA, being able to distinguish between colonized or actively infected patient is still a limitation of the current methodology. And as I briefly alluded to it, the tests are not necessarily standardized across different platforms, so that results obtained in one institution don't necessarily translate to one across different institutions. And HSV6 at this time still does not have WHO standard to be able to fix this particular problem. So this is some of the gap, and there are a couple of methodology out there that are aiming at helping with answering some or filling some of these unmet needs. One of these methodology is digital PCR. So digital PCR is not necessarily an emerging technique in the pure sense of the word, because the first report of digital PCR go back to, I want to say, the early 1990s. However, novel application of this methodology is actually making its way into the clinical laboratory. And this is exemplified by the fact that, especially in oncology, digital PCR is used a little bit more frequently. In microbiology, because of the challenges we have with some of our assays, we are now looking at digital application of digital PCR for infectious disease. And then just as a quick reminder, the difference between digital PCR and real-time PCR really relies in the fact that unlike real-time PCR, you don't really need an external standard curve to quantify the amount of DNA that you have for a particular target. But more so, it's also an approach to amplifying DNA at the single cell level, so much so that you start with your total DNA, you partition it into wells or drop, depending on the platform that you use, and you amplify each one of these targets independently of the other. So there is less competition among the different targets in a solution. And then, as the word says, digital, you sort of count the number of wells that are positive for a particular target with a different color. And these 2D scatter plots would show, for example, that you have 10 positive well for something that's labeled with FAM versus fake. And this is how you essentially measure the total number of targets that you have. And in that sense, then you would hope that there is more standardization across different platforms. If we go back to our particular case, how does digital PCR help? Well, since we're looking at the integration of the human HSV6 virus into the human genome, looking at a ratio of human host versus the HSV6 virus is one approach that some of the investigators have looked at to answer that question of, is it an actual infection or is it a reactivation, or is it an integrated virus? So a study that was published by Dr. Kim Jerome and colleague at WashU shows that by designing primer for both HSV6 and a ribonuclease, which would be a host genome, you could look at a ratio of the HSV6 to the ribonuclease and determine if that ratio will be suggestive of integration or not. So if you got a sample, you did your Buffy code, had your white blood cells, and you perform your PCR, your digital PCR there, where there's no competition between your target, you could count the number of cells that had HSV6 and the number of target that had the RPP30 host gene. And if this was on a 1-to-1 ratio, that would suggest that the patient had an integrated virus as opposed to an active infection where the virus would be replicating completely independently from the host genome. So this was one approach. And when we looked at this for our patient, the whole blood sample had about 8,000 copies compared to the plasma. So remember that one of the ways you could look at this was much higher viral load in the patient. However, this was not greater than 5.5 copies. And if we had had a digital PCR assay, we could have looked to see if there was a 1-to-1 ratio. But based on the methodology that we had at the time, the patient was treated as if this was an HSV6 reactivation, which they're really never clear. And because of the many other comorbidity, it was suggested that this was not integration, but probably a reactivation. But better methodology would have really helped make the case for one of this particular syndrome. In addition to HSV6, which is a very specific application of digital PCR, there's been other suggestions of where digital PCR as a method can really help fill some of the gap for infectious disease. So, for example, looking at cell-free human papillomavirus, which then marries oncology to infectious disease in terms of being able to monitor for minimal residual disease in plasma sample as opposed to biopsy sample. Absolute quantification, so to help with that standardization of viral testing across lab. In mycobacterium, if you can, again, be able to detect those very rare instances of where something's positive, a mutant in the larger set of positive Mycobacterium tuberculosis organism, you may be able to have a better application of this. And also for help with standardization of some of the reference material and that are used to standardize tests across platform. So a few gaps that hopefully this methodology would be able to fill in terms of molecular diagnostic. The image that I showed you a bit earlier was that of a Biorad instrument. However, there are multiple other platforms on the market to also look at performing digital PCR, and those are listed here. Okay, so we move on now to case number 2. And case number 2 is that of a 70-year-old lady, I'm missing the age here, but this patient had AML, acute myeloid leukemia, and was being treated with chemotherapy. And this diagnosis occurred a few months before the current presentation. And so on the presentation that is going to highlight the cases here, she presented to our urgent care with a fever of 102 degrees. And she also was suffering from urinary tract infection, dysuria. So she was given some ciprofloxacin, but also we collected a couple blood culture. On May 27, the day of her presentation, she was given drug and sent home. And 3 days later, her blood culture turned positive. So I'll take just a minute to think about this, right? Because it took 3 days for the blood culture to flag positive. And this patient, if really was septic, is really not an acceptable time period, because the studies that have been published, and particularly this one by Kumar, that was published almost 20 years ago at this point, really show that early recognition of sepsis is key in preventing, in preventing mortality from this particular syndrome. So survival from septic shock is directly related to the duration of hypotension before initiation of antimicrobial therapy. So because of that, because it's so important to get the patient on therapy really quickly, most clinicians will not wait for the result of a blood culture to at least give the patient the right antibiotic. So right now we do a lot of empiric treatment for sepsis because of the limitation in some of our current diagnoses. So to review quickly, a blood culture workflow starts, specimen comes in the lab, the specimen is inoculated in a blood culture at the bedside. The blood culture is sent to the lab. We put it on a monitoring instrument, and once the blood culture flags positive, we'll do a gram stain and report a preliminary result of, in this particular case, GPCC, standing for gram-positive cocci in cluster. Right? So you have your collection, it goes positive, you get a gram stain, and then you have your first preliminary report. It may be a couple of minutes later or a few hours, depending on the methodology. You have a report where you have a specific organism. In this particular case, we'll say Staph aureus. And then it will take a few more minutes to get a few more days sometimes to get a report on the susceptibility result to determine what are the best drugs to treat with that. So you can see from here that this takes anywhere from hours to days, 2 hours to days. So a patient like the one we had took 3 days to get a result of positive blood culture. So we are already 3 days here. And then additional time for the identification and susceptibility testing. So molecular diagnostics have been very helpful in trying to move that needle closer to the time that the patient was seen. However, we still look at this in terms of being able to do molecular diagnostic from a positive culture versus a positive specimen, versus an actual specimen collected from the patient. So if we start with culture, there are a series of molecular diagnostic tests, and they can be either amplification-based or non-amplification-based, that can be used to facilitate the identification of an organism, but only once a bottle is turned positive. So here I'm listing a handful of those. That goes from the very simple, like a peony fish, looking at a positive blood culture, incubating with probes and looking for fluorescence, to one of the more recent platform, sort of a improved version of the fish, where you have a panel of organisms that you can look, that you can test your positive blood culture for in order to get an idea of the organism and also some susceptibility result. So there are some non-amplification methods and then some amplification methods that are based primarily on multiplexed PCR. And depending on the platform, it can be quite extensive or really limited to either just one target or two, or to anywhere as many as sometimes 30 organisms, right? And so with this molecular platform, the impact has been that once you have your positive blood culture and you do your gram stain, and depending on the platform, you may not need to do a gram stain, you go from anywhere from 20 minutes to a couple hours to be able to give your clinician a result. So that's been very significant in moving that timeline to a little bit earlier, so that your preliminary report of Staph aureus is much earlier. And depending on the platform, you may even get to provide a susceptibility result in a time frame that is actionable for patient and physician. The gold standard would still be able to, instead of waiting for a blood culture, being able to grab a clinical specimen from the patient and perform testing directly on that clinical specimen without the need for the pre-incubation for a blood culture. And to date, only one molecular platform has been able to accomplish that, and it's listed here, the T2 Biosystem. Looking at this multiplex PCR assay, that takes approximately 7 hours to turn around, but you're starting directly from a 2 ml blood sample and through a series of steps, being able to identify a few gram-positive, a few gram-negative, and some candida. So I've listed here for the gram-positive and gram-negative organism. Those will be the 5 that you can identify by T2, and the 5 yeasts that can be identified directly from a clinical blood sample. So with that, your workflow is even more improved in the sense that you collect your sample. You don't have to wait a couple of days or that it takes for a blood culture to turn positive. You can have a result within 7 hours if you're performing them as you get the sample. But in order to get some information as far as what drugs to test with this, you still need the blood culture. So this helps, but doesn't completely replace anything. So if we go back to our patient, in the case, the isolate was here identified as Rhodia mucilaginosa, and the patient was switched from vancomycin to ceftriaxone. However, this case highlights some of the benefit that multiplex PCR have brought to the diagnosis of infectious disease. Multiplex NAT have allowed for more rapid diagnosis, especially when you start from a positive blood culture without the need to isolate the organism before being able to identify this. However, this is also just complementing traditional diagnosis. And it's beneficial because you are able to turn this around in time in a few hours. And depending on the methodology that is used, you can actually implement targeted therapy for the patient. But there are still gaps that exist because, as you can see from the previous image, I should highlight this, just a picture of like the microbiome of the human being. We have so many pathogens that the assays that we currently have are not really designed to target everything. They're designed to target the most common. And our particular patient was positive by Rhodia, which is actually not present on any of the current commercial molecular tests. So this is a limitation of what we currently have. Although there's been a huge improvement, we still have gap in being able to capture anything that can make patients sick. And the sensitivity of direct detection from whole blood sample is relatively limited, which is why the majority of testing at this time is still focused on detection in blood culture sample. One methodology that is emerging as an option to solve this problem is on next-gen sequencing. So in this particular study that was published this is actually an article review that was published by Trish Semner from Hopkins about last year. She does a good job of showing the traditional workflow, which we briefly touched upon, right? You get your culture, you have to do ID, to wait for things to grow, and so on. And this takes anywhere from a few hours to many hours, and in some cases, several weeks. With whole genome sequencing, especially if you're looking at an unbiased approach to diagnosis, you will be able to take any clinical sample, do your extraction, convert RNA to DNA if needed, your library prep, your sequencing, which will take about 24 hours, but depending again on your run, it could be 48 hours, to your analysis. And all of this would replace all of these different methodology and be able to do this one test to identify the organisms that may be on the cause of sepsis, right? And here just showing a different platform that are out there right now on the market to be able to do next-gen sequencing. So this will be one application of next-generation sequencing in infectious disease, which is metagenomic, where it's an untargeted, or it could be targeted for bacteria. So let's say it was 16S amplicon sequencing. In this particular case, it would allow for increased sensitivity in the detection of bacterial ID, or viruses, discovery of other pathogens if you were just doing metagenomics, right? So there's multiple ways this could go. And application for ID is also in terms of looking at whole genome sequencing and looking at potentially directly on an isolate and getting information that can even relate to susceptibility of the organism for targeted therapy. The challenges with NGS, however, at this time is that it's still not quite practical, but we're coming there. This is an emerging technology that has a lot of hopes. But the time still is very long again, right? So we'll be looking at this patient where it was about 3 days. If it takes 3 days for whole genome sequencing result, then that hasn't really come to fruition completely. There's some challenge with bioinformatics and data analysis. The cost of the assay has come down. However, it's still quite significant compared to blood culture. And there's still a lot of skills that is required from clinical microbiology laboratory to acquire to be able to perform this test. And similar to what we talked about for viral testing, there's still not really much standardization for those who are performing this test. This is an emerging technology. It's very exciting, and we'll see how this comes up as many of these gets resolved, many of these issues gets resolved. Other diagnostic that are emerging that could fill this need and this gap is CRISPR-Cas. So CRISPR-Cas was discovered a few years ago in terms of modification of genetic material, but now this method is has been evaluated and is shown to be a potential approach to doing rapid diagnosis from any sample and looking for any target, and you could construct your guide RNA to detect specific target. And by doing this, you would be able to not only use this methodology in a much more rapid time frame, but this could also be available for resource poor setting or point of care setting. So again, speeding up the timing that it takes for us to get this ID. So CRISPR-Cas is another diagnostic method for infectious disease that we will keep an eye on. Just to summarize today's talk, we really have several existing technology like digital PCR that's been around for a while, but now we are finding application in diagnostic for infectious disease. But we also have emerging technology such as whole genome sequencing or CRISPR-Cas that have the potential to really impact clinical care. However, we do still have some gaps that are remaining, but hopefully in the next few years, this will become less of an issue, and this methodology could complement or replace some of the still a little bit cumbersome traditional tests that we are currently doing. So I'm going to stop here, and I will be happy to respond to any question that you may have once I receive them by email. So thank you very much for your time, and I will stop here. Thank you.
And thank you, Dr. Babady, for that informative presentation. I'd like to thank LabRoots for making today's educational webcast possible. As a final reminder, Dr. Babady will follow up with any questions you've submitted via email. That's all for now, and thank you for joining us. We will see you soon.